Thank you. Good morning, and thank you so much for the kind introduction and the invitation to speak. It's a pleasure to be with you and just provide an overview of an important topic. It's actually several topics that pertain to acromegaly in our patients and all the conditions that are associated that people with acromegaly are more likely to experience. I will try to be very, very clear, minimize any technical jargon. I apologize if there's any. Some of the slides may look technical, but you don't have to pay too much attention to them. They're there if somebody is interested in more information. So going back to acromegaly, of course, we and our patients understandably are interested and concerned about some of the physical manifestations, the tumor itself and its effects on the body, especially vision, headaches, and the effects on the pituitary function. But in addition, there's a host of other metabolic and other conditions that people with acromegaly are more prone to, and these may include high blood pressure, diabetes, heart disease, sleep apnea, tumors, and bone and joint abnormalities. So I will be touching upon some of these problems and give you just highlights pertaining to these conditions. So starting perhaps with the most controversial of them is tumors. There's a lot of controversy as to whether people with acromegaly are more prone to tumors. And again, don't pay attention to the technical details, but this is just a summary, an overview of different studies in the literature that report on the topic. And the bottom line is shown at the very end. In the red square, the little diamond shows you that in aggregate, if you sum up all the information, all the data, people with acromegaly appear to be 50% more likely than the general population in terms of developing tumors. And of course, this is what we call a relative risk, which means that it doesn't mean that 50% of people will develop tumors, but if the general population has a risk of 5 per year, 5%, then people with acromegaly would be 7.5%. And notice that some of the studies find actually even a protective effect, the minority of them. So this is not unequivocal, but nonetheless, the majority of them do find that to be the case. And particularly colon cancer, colon polyps and colon cancer appear to be of greater concern in the studies for colon cancer, but also some other cancers, thyroid, gastric, perhaps breast and urinary tract cancer. Now, there's a lot of controversy because of the way some of these studies have been done. For example, especially when it comes to thyroid, our patients are usually cared for by endocrinologists who will feel their thyroid, so they're more likely to detect a tumor there. So a lot of it may have to do with the fact that simply patients with acromegaly are more likely to be surveilled more intensely. But nonetheless, there seems to be a real issue there, particularly with regards to colon cancer and other tumors. And indeed, a more recent study from Sweden, which was a nationwide study, as you can see, over 1,200 patients, close to 1,300, found that both benign tumors and malignant tumors, cancers, were more likely to occur. About 2.5 times more likely for benign tumors and about 1.3 times more likely for malignant tumors, and especially colon tumors, colon polyps and colon cancer, but also lipomas, benign tumors such as skin tumors, skin tags are especially more common. So it is generally, most professional societies have recommended particularly surveillance for colon polyps and colon cancer with colonoscopies, and I will get back to that, but that's one of the things that certainly we should all be paying attention to. And I should again take the moment to emphasize that multidisciplinary care is essential in the care of our patients with acromegaly. It really takes a village for our patients to thrive and feel their best. So switch gears a little bit to talk about, touch upon high blood pressure and diabetes, high blood sugar. These are an overview of information of a study from Mexico showing that both diabetes on top and high blood pressure at the bottom are more common compared to the general population in Mexico, but also many other studies have found the same. So about a third of patients with acromegaly have diabetes and also high blood pressure. And although you can see that people who are in remission after surgery are less likely to develop diabetes, other patients who are controlled on medication still have the same risk, it appears. And that could be because some of these medications that we use can raise blood sugars, and I'm sure this will be discussed in later talks. But nonetheless, in general, we often find that high blood pressure and diabetes are easier to control with treatment of the disease and lowering of the growth hormone and the IGF-1 levels. Now, high blood pressure and diabetes, I'm sure you're all familiar with their importance in general with regards to the risk for, their importance as factors, as risk factors for heart disease. And indeed, in patients with acromegaly, that's also the case. Just to summarize information from another study in Sweden comparing patients with diabetes and acromegaly to those who had acromegaly alone. So in the teal color are patients with acromegaly and diabetes, and in the pink color, only acromegaly. And what the graph shows, the overview, is that people with diabetes plus acromegaly were more likely, about 50% more likely, to develop heart disease over time. And so at the same time, it's important to point out that if you treat the acromegaly, lower the growth hormone, heart disease often improves. The thickening of the heart muscle that we often see with acromegaly, especially at diagnosis, gets better. So it's very important to diagnose and treat the condition appropriately and completely. And even a more recent study from South Korea looked at a very large number of patients, about 1,800 with acromegaly and over 9,000 healthy people. And again, I won't bother you with the technical details, but the bottom parts of the graph show that people with acromegaly were more likely to develop certain heart conditions, atrial fibrillation and heart failure, about 1.5 times more likely. Atrial fibrillation, you may be familiar with. It's a common type of irregular heart rhythm. Some people may have palpitations, breathing trouble, tiredness, and if untreated, it can increase the chance of developing stroke over time. Heart failure, of course, can cause many symptoms: breathing trouble, swelling, and fatigue. So these are very important to treat. Again, diagnosing the disease early and treating it appropriately it will likely mitigate, especially the risk of heart disease, and help reduce the abnormalities that we see on ultrasound examinations of the heart, echocardiogram. So the bottom line is that for all our patients with acromegaly, it's important to have a EKG, a cardiogram, and also an ultrasound examination of the heart, an echocardiogram as it's known, to detect these problems. And as I mentioned, the endocrinologist and the primary care may often need to refer these patients to a cardiologist if there are problems. Talking a little bit about sleep apnea, that's another common condition in people with acromegaly. Sleep apnea can happen because of soft tissue swelling in the air pipes, the airway, and that can block the airway at night when the tongue falls back during sleep. And then people experience not only snoring, but also the breathing stops. They may wake up with headaches. They may feel groggy during the day. They're not productive. So it's important to diagnose and to treat. And this study shows you, the left panel here, that at the time of diagnosis, about 3/4 of people with acromegaly had sleep apnea, but when the condition over time is diagnosed and treated, it largely reverses back to normal. So it's very, very important to monitor our patients to, first of all, ask for these symptoms, and then if they have symptoms suggestive that suggest the condition, have a sleep study, and then be referred for appropriate care. Also, another study that reviewed the results of many different investigations reported that sleep apnea improves with treatment of acromegaly, again highlighting the importance of early diagnosis and treatment. So that's also another part of important care. And I will switch gears a little bit to talk about bone disease. There's also important risk of arthritis, osteoarthritis, but I will touch upon bone disease in the next few minutes. Older studies had reported that the bones of people with acromegaly tend to be strong, and this is again a summary slide showing findings from what we call DEXA. It's a type of an X-ray. When people lie on a table, they have a picture of the spine and the hip checked, and that's usually done to look for osteoporosis, for example, in people over 50s and who may develop more prone to osteoporosis. So initially, especially if you here see in the spine, the bones of people with acromegaly seem to be strong, well mineralized, having a lot of calcium in general, and the same even more so in the hip. But so it came perhaps as a surprise that when different investigators looked at studies, they found that they examined the risk of breaking a bone in the spine, having vertebral fractures. They found that this was not trivial. If you, again, look at different studies, and in total, close to 40% of people with acromegaly had abnormalities in their spine that were consistent with a fracture and not necessarily causing symptoms, not necessarily causing acute pain, but perhaps contributing to chronic pain in many cases. So the question is, why is this discrepancy? Why do people are more likely to break bones? And so the answer seems to be, and also I should say that in other studies, people having active disease, having high IGF-1 and growth hormone levels are more likely to develop fractures compared to those who have controlled disease, again, highlighting the importance of controlling the disease, diagnosing it early, and treating it appropriately. So the answer, at least in part, seems to have to do with bone microarchitecture. This is the fine structure of the bone. So this is a CAT scan, a special kind of a CAT scan of the bone in high resolution. So you can magnify and put a magnifying lens onto the bone. And this is the forearm, these bones, and again here the radius, so the big bone here, and then the tibia, which is the bigger bone in the lower leg. And you can see that if you magnify them, if you blow them up, there is, the bone consists of a cortex, which is fairly compact, and then a trabecular component, which is more includes many struts, right? And these abnormalities of microstructure in bone have been found to be predictive of the risk of fracture in people with osteoporosis, for example, postmenopausal osteoporosis. But it turns out that they may play a role in our patients with acromegaly as well. And we and others have studied this issue. I'm just going to give you some highlights. Again, don't worry about the technical details. These are some of our patients with acromegaly compared to healthy individuals. Of course, they had high IGF-1 levels. At diagnosis, some of them had low testosterone. This is a study in men. But even after we excluded patients with testosterone, it turns out that our patients with acromegaly, we had abnormalities in their bone microstructure. Their cortical bone, the surrounding area, was thickened. But at the same time, the trabecular component inside was weakened. So you can see they had lower bone density and thickness in the inner component of the bones, which makes them more prone to fracture. And this is what this looks like. If you look at, again, with this technique, you can see the cortex is thickened compared to the healthy person, but the inside seems to be weakened. It's more rarefied. And that seems to be account, at least in part, for the risk of fracture in our patients. So what we generally recommend, many our colleagues and professional societies recommend not only the bone density, but also some assessment of the spine. There are a number of ways to do that, although not all of them are available commercially. Certainly the CAT scan I mentioned is a research tool. It's not widely available, but there are other ways that one can look at the spine, even with X-rays or other means that are becoming more readily available and approved by insurance gradually, that may allow us to look at the fractures, the risk of our patients with regards to fracture. And actually, we collaborated. We did the same study in women, and you can see in the women as well, about 29% had fractures in the spine compared to 0 in the healthy controls. And again, this is a woman with acromegaly, active acromegaly compared to a healthy person. Again, you can see that although the cortex is thickened, the inner component is somewhat impaired, which may account for the increased fracture risk. So these are some of the things that we all need to be concerned with. And indeed, as a physician, sometimes we tend to be concerned or be aware of the growth hormone levels, the tumor itself, and the pituitary hormone deficiencies, but our patients also live through this. All these comorbidities that may affect their quality of life and affect their ability to work and enjoy life. And I know that you're going to have a talk later this afternoon to focus on this issue, a very important issue. And why, again, is it important to diagnose the disease early as possible? This is a study from Sweden, over 600 patients, looking at the number of comorbidities in acromegaly in relation to the diagnostic delay, how long it took to diagnose the disease. And you can see that the longer it took to diagnose the disease, the more the comorbidities. So again, it's very, very important to diagnose it early, and you're going to have excellent talks coming up about the diagnosis and treatment of acromegaly. So in summary, these are some of the things that have been recommended, and I apologize if these are small, but the professional societies and our unit staff, we advise our patients to have their blood pressure checked. They will be checking that every time they come to their clinic and they see their PCP, an echocardiogram, and ultrasound of the heart and cardiogram. EKG should be done at least at diagnosis, and then depending on their condition, perhaps repeated. Sleep study may be needed, should be done if somebody has symptoms, snoring, breathing interruptions. Blood sugars, we often check the A1C, that's a measure of the blood sugars in the past 3 months. The rest of their pituitary function will generally be assessed by the endocrinologist. And then bone health, to look at using DEXA, but also spine assessment. Colonoscopies are important, at least at diagnosis, and then every 10 years, if they show no polyps or other concerning findings, and perhaps more often depending upon the disease control. And quality of life, you're going to hear about that. So these are all important components of patient care. And the endocrinologist and the PCP, they both have important roles in coordinating the care of these patients. It clearly takes a number of doctors and specialists to bring this to complete all these tests and follow through. So again, in summary, I think we have an improved understanding of the comorbidities in our patients with acromegaly, and it's so important to minimize delays in diagnosis in order to minimize the number of comorbidities that our patients develop over time. But by the same token, surveillance for these comorbidities is an essential component of a good patient care. And I think that we have information now that early diagnosis, prompt treatment, that controls the disease early is very important, critical to limit comorbidities and improve the long-term outlook for our patients. So I'd like to thank you, and I'll be happy to answer any questions.